Good morning, everyone. Cynthia Lambert, Executive Director of the Kentucky Population Health Institute. And I want to welcome you to our final webinar of the Children's Environmental Health Summit 2020. We're one of the co-sponsors of this event, and changing our annual summit to it's 8 webinars has been both a learning experience for us, but it's been an opportunity to gain a larger audience. We're so happy you all are here. Plus, I'm the person that sees all the evaluations that you fill out. Nobody's complained about how difficult it is to choose between all the different breakout sessions or that the bathroom lines are too long. So that's a win, right? So we're going to get started. I have a welcome message from the Enviro Health Link staff at the Department for Public Health that acknowledges all the folks that helped put this together and tells a little bit about Enviro Health Link. So let me share that with you.
Hello, and welcome to the Kentucky Children's Environmental Health Webinar Series. The purpose of this series is to help participants increase their knowledge of environmental exposures and how to reduce these for children. We would also like to introduce you to our Environmental Public Health Tracking Data Portal, which you can access by going to envirohealthlink.org. This easy-to-use website can be used to find Kentucky-specific health and environmental data. We want to say thank you to our sponsors for their support: the Kentucky Department for Public Health, the Environmental Public Health Tracking Program, the Kentucky Environmental Education Council, the Kentucky Asthma Management Program, the Kentucky Population Health Institute, and the University of Kentucky's Center for Appalachian Research and Environmental Sciences. And finally, we would like to say thank you to our planning committee, whose valuable input and expertise has made this series possible. We hope you enjoy our webinar series.
Welcome, everybody. I'm Shelly Canada. I'm with the Environmental Public Health Tracking Program. And as Cynthia said, this is the last in our series for 2020. And these will all be archived and lodged on Train Kentucky, which is a public health learning management system. We will still be offering free continuing education credit hours, and the webinar series will be free. It gives me great pleasure today to introduce our speaker, Dr. Connie White, who will be talking about adverse childhood experiences, otherwise known as ACEs. I've had the privilege and the honor of working with Dr. White on a variety of projects for the Kentucky Department for Public Health for many years. Dr. Connie Gail White is the Deputy Commissioner for Clinical Services at the Kentucky Department for Public Health. She has practiced as an OB/GYN physician in Frankfort, Kentucky for over 20 years. She retired from clinical medicine and first worked at the Kentucky Department for Public Health as the director of the Division of Women's Health in 2009. She then joined the College of Public Health as a clinical professor at the University of Kentucky in 2011 in the Department for Health Behavior. Dr. White returned to Kentucky Department for Public Health as the Deputy Commissioner of Clinical Affairs in 2011. She has served as a principal investigator for multiple grants, including my own, that included chronic disease, cancer screening, and substance use disorder, among many others. She is currently involved in the state pandemic response. Dr. White is a graduate of Kentucky Wesleyan College with a BS degree in chemistry, and she earned an MS in toxicology from the University of Kentucky and worked as a researcher in teratology at the National Center for Toxicological Research in Little Rock, Arkansas. She completed her medical school training at UK and an OB/GYN residency at the University of Louisville. She is certified in OB/GYN by the American Board of Obstetrics and Gynecology. Dr. White is active in American College of OB/GYN, ACOG, which is her professional organization, and she currently is holding a district office. Thank you, Dr. White, and I'm going to turn it over to you.
Well, thank you so much for that kind introduction, Shelly. That's so awkward to figure out who you're supposed to look at when something like that is happening. So thank you everyone for being here. and I'm going to get us going. What I want to do is I want everyone to learn a new skill that you didn't know you had on your computer. Take your cursor and hover it up to the top of the screen where you're going to see a drop down box that says View Options. So go up to the top of your screen, you're going to see View Options, and you click on that, and you're going to see something that says Annotate. And if you click on Annotate, there's going to be some icons that are coming up. I'd want you to either use the star or the heart to tap on that option and then go down in here and tap on the county. Oops, tap on the county. I can't do that, but tap on the county where you are right now so we can get an idea. Thank you. We can get an idea to see where people are listening from. I think that helps us all to get a little bit better idea that we know that we are coming from all breadths and depths of the Commonwealth, because these issues are so critical. Our children's health, our children's well-being is what we are all so very excited about, and that's why we're all here right now. So we appreciate everyone who's here today, and even though I have given a talk on ACEs, this one's going to be a bit different, and I hope you'll be able to take something home from it that will be helpful for you in the work that you're doing. So we've got quite a few folks still joining us. And I always like to tell people I grew up in Taylor County, which is this county right here, because you can tell it's Taylor County because it's shaped like a heart. And that makes it easy to find. Okay, well, thanks everybody for participating. Now, someone in the headquarters, thank you for taking that off. So we're going to talk about adverse childhood experiences and diseases of despair. And resilience. I never want to leave off the phrase resilience because that's terribly important. We don't want to look at adverse childhood experiences, and we'll talk a little bit on one of the slides, as this is fate. This is not fate. This is just, it explains a lot of things and helps us to know how to design our programs and our efforts so we can be sure and help people overcome adverse childhood experiences. If I were in person right now, I would ask all of you, and go down to the chat box. What do you see when you see this? What do you think? What words come to mind? This is one of my favorite pictures of the whole world. It shows, I think, it shows diversity. It shows curiosity. It shows sharing. It shows learning. It shows a lot of things that I think, oh, yeah, they're coming up in the box now. And of course, I can't see them and talk at the same time. So we've got love, playful, exploring, affection, curiosity. These babies are adorable. So then look around where you're working right now and say, what happened to everybody? How come we're not that special and sweet and adorable right now? Well, a lot of things happen to these babies, but before they turned from the time they were these babies and they turned into us. So what we're going to talk about today is what happened and how has that changed these vulnerable and curious minds. Okay. This is one of my second favorite pictures in the whole world, and that you can, without any sound, you can hear that woman cooing to that baby, and you can hear that baby gurgling and drooling and trying to talk back in a response. This is called, it's the back and forth of mom says ooh and the baby says ah, and that communication starts very, very early. During those first 2 years, from birth to 2 years, this baby is making about 700 to 1,000 new connections per minute in the brain. 700 to 1,000 a minute in that baby brain. We're all born with the brain, but those connections between those neurons talking to each other, laying down pathways so that the brain works and develops into an adult brain and hardwires that social emotional development is extremely critical. So social emotional development is based on that secure attachment. That woman, and we'll assume it's a mother, and that baby are developing that secure attachment that is so critical. I have to quit moving my cursor because I'm messing myself up. That is so critical in this baby's development. So the nurturing relationship with the caregiver is what has to be there for those neurologic developments to happen at a pace that we want to see that child develop naturally. So we are not born with the skills that enable us to make plans, control impulses, and stay focused, but we are born with the potential to develop these capabilities, and that's what we're going to be focusing on today. So I always joke this is one of my favorite pictures out of the medical journal Time magazine. This was in Time magazine eons ago, but it very clearly to me shows exactly the kinds of things that we're interested in. This is a PET scan, and this is it's dissecting right across where my hands are right now. At the top you see the front where the nose is, and it goes to the back of the head, and it's looking at the brain on the left side of a healthy 2-year-old, and on the right side is a child. And this extreme deprivation they're talking about has to do with children that were in orphanages in Romania before the fall of communism and the USSR. And these babies were put into these orphanages. They were fed, they were changed, they were swaddled, they were laid down, and then the attendant went to the next baby and the next baby and the next baby. And then so many hours later, somebody came back and fed and diapered and swaddled and put that baby down. So they got care. They were not underfed, they were clean, but they did not have that attachment, that adult bonding that we mentioned in the slide before. And this shows you the colors, the red colors and the green colors are showing you neurologic activity in this baby's brain versus neurologic activity in this baby's brain. And you can see that in this baby's brain, there are parts of that brain infrastructure that are not actively functioning. This doesn't mean this child has a developmental delay as far as we would think about putting that child into a developmentally delayed childhood program. But this child is not laying down neural pathways at age 2 that are going to be critically important for that child's development. Their love of learning, their sense of self, their positive ability to develop positive social skills, understanding emotions, understanding commitment, understanding morality. These things, if those pathways aren't developed, are not developing for this child. If that child sits down and reads a page out of a book, and you turn that page and then you look at that child and say, what did you remember? They don't remember. It's not that they're being difficult, but they don't have the neural pathways to allow them to remember. And this is where adverse childhood experiences comes in. Now, I'm in public health, and public health loves acronyms, and public health loves pyramids. I'm not quite sure why we're all about pyramids, but many public health concepts are based on pyramids. So this shows adverse childhood experiences that will then lead to social, emotional, and cognitive impairment, adoption of health risks, um, disease and social problems. And I have no idea what that did. Let me go back and reshare. Again, I tapped on something I wasn't supposed to be tapping on. Okay. And then leading to early death. So this is starting from conception all the way up to death. And this is what I have spoken of in the past. And so we're going to start with conception. We're going to go through this pyramid, and then I want to introduce another concept to you of ACEs that is not adverse childhood experiences, but it's something that happens even before conception. So this is the life course perspective, and please don't tell my mother, but I'm going to use her as an example. So right here is where we have conception, and we're looking at a middle-class white woman. This is what this original concept was in 2003 by Dr. Michael Liu. This doesn't look like anything earth-shattering, but in 2003, this concept was very earth-shattering. And his example here was a young African-American woman, and what happened during the life course. These up arrows are her protective factors in her life. So let's start with my mother. My mother tried to get pregnant with me for 2 years, couldn't get pregnant, went and had some kind of mysterious surgery, which I've never figured out, but she was pregnant with me relatively relatively soon. So her first down arrow was her fear that she couldn't have a baby. She was married to my father. She lived in a house that they rented, but they were able to afford rent. He had a job. She had food. She was able to afford to go for prenatal care. And boom, I was born. She had her little girl. She got a sewing machine for Christmas. Life was wonderful. She had her little boy, she had her little girl, and everything was great. She had her downs along her life. And then I was born. So this is where the pregnancy comes in. So when she got pregnant with me, she was in a good place to have a healthy pregnancy. This here is the example that was used in this paper in 2003 was a young African American woman who was not married, who was a victim of rape, who didn't get any prenatal care, had family members that loved her, but had a lot of things going against her. And then that child was born. That child then went through a lot of risk factors in her lifetime. So when that child became pregnant, they were starting out at a very different place than the child that my mother delivered when that child became pregnant. That would have been me. I don't have any children, but had I been pregnant, I would have started out at a different place, not only because of what happened to me in my adolescence and my childhood, but also from conception to birth, what happened for me to make me get to a state of pregnancy. I've presented this to a room full of OBGYN physicians, and some of them were actually in tears because as an OBGYN physician, you work so hard, you do your best for everybody. And some people just have outcomes that you can't explain. And now we can understand it. You can explain it because people start out at a different place. So if we do the same for everybody, if I do the same for this pregnant person as I do for this pregnant person, she's not going to have as good of an outcome. It's not a reflection on me as being a bad physician. It just means that when I'm working with this woman, I have to do things differently for her if I'm wanting her to have a good outcome. Toxic stress is what we worry about with adverse childhood experiences. And I think you can do definitions and do a whole lecture on toxic stress. But to me, this defines what toxic stress is to children as they're growing up. So let's talk about adverse childhood experiences and how that whole process developed. I usually do that this part of the presentation when that slide before is up, but I find that slide before so upsetting, I just decided to skip ahead. I have a almost 5-year-old granddaughter, and just looking at that picture is just too heart-wrenching for me. Back in the 90s, there was an endocrinologist who was working with the super morbidly obese clients in his practice, trying to help them with weight loss. He was seeing them weekly. People were doing well. They were losing their weight. He was, as physicians tend to be, very proud of himself and his successes. And he said, gosh, you're doing so well. Why don't y'all come back in 3 months? So the patients started coming back individually in 3 months. And what he found was that many or most of them gained all of their weight back. He was shocked. He didn't understand. He thought he had done this wonderful job with these patients and that they had suddenly overcome their supermorbid obesity. And he got this novel idea, let me just ask them some questions and find out what's really going on with them. And what he found out over time was that most of these patients had had severe traumatic experiences as children, and they had hidden behind their weight. And when they lost that weight working with him, people began to recognize them and say, gosh, you're looking great. You look good in that dress. It's good to see you looking so good. And the last thing that these people wanted was to be seen. So they gained their weight back so they could fade into the wallpaper and not be the center of attention. So he wrote this up and did a small paper about this, and he presented it at a meeting, and someone came up to him and said, hey, you need to, Dr. Folletti, you need to talk with Dr. Anda at the CDC because he's found the very same thing with people with heart disease. Now, Dr. Folletti had never heard this link with obesity and trauma. in medical school, and certainly nothing about trauma and cardiac disease. So he got together with this gentleman, and they got Kaiser Permanente back in the 90s, which was at that time mainly in just California. And so you're looking at a population of mostly white, mostly middle class, mostly employed, or they wouldn't have this health insurance people. And so they got Kaiser Permanente to agree that after people came in for their yearly examination, they mailed them a survey. And I know for some of you that's an odd concept, but you actually put in an envelope and put a stamp on it and mailed it to people. And they got this survey out and they answered these questions with a pencil, and mailed them back. And then they followed these people. And what they found was that the more adverse childhood experiences that these people reported, not where they were in their lifetime right now, but things that happened to them before they were 18 years of age, um, the more trauma they had experienced, the more chronic disease they had, and early death. So in 2015 and again in 2018, our Department for Public Health Behavioral Risk Factor Survey it's called BRFIS. I joke that when I first came to the Department of Public Health, I figured that BRFIS was probably a country in Eastern Europe. I'd never heard of BRFIS before. BRFIS has been around since 1985. We get a little bit of funding to each state and territory to ask a set of questions. And we do a telephone survey and ask people questions about their health. We ask them things like, do you smoke cigarettes? Have you had a colonoscopy? Have you ever been diagnosed with diabetes? A whole set of questions that every state asks, but we as each individual state can add questions. So we decided to add the ACEs questions to our BRFIS survey in 2015 and 2018. So the ACEs module, Adverse Childhood Experience, has 11 questions that fit into 8 categories. And you can see here those are child abuse categories, whether physical, sexual, or emotional, and then household dysfunction. Presence of a mentally ill household member, alcohol, drug use, and we'll go through the questions here on the next couple of slides. I do like to tell people that when you start looking at these questions, they may trigger some trauma in you, and I certainly hope that doesn't happen. You are certainly welcome to drop off if you think you need to do that, but I want to be sure that you understand what these questions are that were asked of people in our BRFIS survey. Around 8,000 people a year are participants in Kentucky in the BRFIS survey. So the questions were to each of these individuals, and nobody in the BRFIS survey is under 18 years of age. So we were asking any adult that answered these questions to look back and tell us, did you ever live with anyone who was depressed, mentally ill, or suicidal? Did you live with anyone that was a problem drinker or an alcoholic? Did you live with anyone who used illegal street drugs or who abused prescription medications? Did you live with anyone who served time or was sentenced to serve time in prison, jail, or a correctional facility? Were your parents separated or divorced? The thinking is not that the separation or the divorce was the problem, it was the stress that led up to the need for that type of an event to happen that would be a stressful event for the child. Did your parents or adults in your home ever slap, kick, hit, punch, or beat each other up? Did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? And they did not include spanking in this. That's another topic that we could talk about at some other time. But in this particular and original work and in the work we did with our Kentucky BRFIS, we did not include spanking. Did an adult or a parent in your home ever swear at you, insult you, or put you down? Did anyone at least 5 years older than you or an adult ever touch you sexually? Ever try to make you touch them sexually or force you to have sex? So those are the 11 questions that were part of our BRFIS survey. Now, when I first started learning about adverse childhood experiences and learned about the questions that were asked, I was in my own little bubble. I just thought, well, nobody's going to answer yes to any of those questions. I had been raised in such a lucky, blessed, privileged environment. And I don't mean privileged as an upper class financially. I mean privileged to be surrounded by love and support and no violence at all. It was beyond me the percentage of our Kentuckians that this was part of their life. The question is just a yes and no question. You don't get a higher score if it happened frequently or if it just happened once. So if you say yes to any of those 11 questions, then you get a point. Of 1 for ACEs. I'm going to breeze through a whole bunch of data, and these PowerPoints will be available to anyone. So please don't try to take notes or anything, just kind of get the concept. But I want to show you how there is a dose response curve for adverse childhood experiences and uh, health outcomes and health behaviors that you will recognize as unhealthy. So this first one is very simple. It showed in all of the slides I'm going to show you next. On the left is 0 ACEs, and on the far right is higher number of ACEs. So this shows you that dose response curve. The higher your ACE score, and this is not Kentucky data. This is all US data. The Kentucky data is coming later. And this is old data, but it still holds true that if you're going to start smoking by age 14, the higher your ACEs score, the more likely that is to happen. This shows that the higher your ACE score is, the more likely you will develop a problem with alcohol misuse and abuse, and even a higher correlation that you will marry an alcoholic, which I find completely fascinating. As an OBGYN physician, these 3 dose response curves meant a lot to me. So if the higher your ACEs score, the more likely you are going to have intercourse by the time you're 15. The more likely you will have a pregnancy in your teenage years, and the more likely you will father a child while you are a teenager, a direct dose response curve that you can see here. This just shows you the correlation between adverse childhood experiences and adult depression. The lighter colored bars are women and the darker colored bars are men. And then we get into heart disease and diabetes. We know that if your ACE score is at least 6, you are 2.2 times more likely to have heart disease, 1 times more likely to have cancer, 1.6 more times likely to have diabetes, and 17 times more likely to have learning and behavioral problems in school. When people have these type of experiences, they often develop coping skills that end up responding to the body. Well, 2 things. Coping skills that are not supportive of good health. That's where cancer and heart disease, diabetes come in. And also we are learning that when these children are stressed at an early age and their cortisol levels are high, that starts an inflammatory process with these children, even at an early age. So they are in an inflammatory cascade starting at younger in their lives. So that's going to trigger the body to develop a lot of these chronic diseases that we're looking at here. You're 4 times more likely to have emphysema or chronic bronchitis. I'm sorry, 400% more likely to have chronic bronchitis or emphysema if your ACE score is 4, and you are 1,200% more likely to try to attempt a suicide. I've never seen 1,200% listed anywhere else in any other data. We know that people with high ACE scores are more likely to be violent, have more miscarriages, broken bones, more drug prescriptions, more depression, more autoimmune diseases. And if your ACE score is 6 or higher, your lifespan is going to be shortened by 20 years. Now, when you're 25, that doesn't sound like a big deal. But when you're over 65, like I am, cutting off 20 years it's the rest of my lifespan for me right now. So we know that ACEs have such a tight correlation. It's as tight as the correlation between lung cancer and smoking. In fact, the ratios are even higher. If we look at academic and health in children with ACEs, this was a study done in Spokane, Washington. So if one being no ACEs, if you have 3 or more ACEs, you are 3 times more likely to have academic failure, 5 times more likely to have attendance problems, 6 times more likely to have severe severe school behavioral concerns, and more frequent poor health issues. As you pull all this together in your head, this becomes very obvious to you why this is happening. Now we're into the Kentucky BRFIS data, and this is 2018 data. So we ask those 11 questions to everyone 18 and over that completed our BRFIS survey. So we ask people, do you eat 5 fruits and vegetables a day, and do you do any kind of physical activity? And at the end, we ask those 11 questions. And this is what we found. And we compared it to 2015, and it was within 1% or 2 as to whether there was any change in these results. So I'm going to show you the basic results, and then we're going to break it down a little more. So this, and I won't read through all these, but this gives you a correlation between if you had, if anyone answered yes to any of these questions, as far as everything from an incarcerated household member down to drinking in the household or separated or divorced. Now, it's real important that you remember these are people that were over 18 years old reflecting on their childhood. It doesn't reflect what's happening to children today. That's not what the ACE survey is about. So it's not what's happening today. It's what happened to you as an adult. So you may be a 65-year-old adult answering this question, and you're looking at what happened 55 years ago. You may be 25, and you may be just looking at what happened to you 6 or 8 years ago. So we broke this down by numbers of ACEs percentage wise. So 40% of people that answered our questions had no ACEs. That's me. That's me in that little bubble right there. That means 60% of people did have ACEs. 21% only reported having answered yes to only one of the questions, all the way down to 11.4% had 5 or more ACEs. So that means more than 1 in 10 of the Kentuckians that answered these questions had at least 5 ACEs in their childhood, which again, for me, is a very frightening thought. So let's break that down even further. This just shows you what our results were in 2015 versus what our results in 2018. So we had more people have 1 or more ACEs in 2018, looking back at their childhood, than reported that in 2015. We took the the clients that answered the questions. Sorry, I'm an old physician, so everybody's a patient. So we took the clients that answered the questions in our BRFIS survey, and we looked at just the people that had that 5 or more ACEs, and we broke them down by age groups. And I think it's very interesting to me when you look at the highest group was the 25 to 34-year-olds. Is it because the older you get, you kind of forget? Or you kind of just assumed it's what everybody had happened to them and you don't remember them as distinct individual events? Or did about 8 years ago something happen differently that would make that age group have a higher incidence of 5 or more ACEs in the 25 to 34-year-old age group? And my thinking is it may have something to do with our opioid crisis, our substance use crisis, but that's to be determined. Let's look at that group with 5 or more ACEs broken down by how the people reported to us over the phone, if they were white, non-Hispanic white, non-Hispanic black, multiracial, or if they said that they were Hispanic. And so the numbers of Hispanics were smaller because the population is smaller, but they were certainly a higher response to adverse childhood experience questions in the Hispanic group. This is breaking it down by their education. So we go everything from less than a high school degree all the way up to college graduate. I can't parse this out, but I think it's very interesting that some college was 13.3 and it went down to 8.1 for college graduates. Did those high ACE scores interfere or intervene to keep those people from not completing college, and the ones that were able to complete college had fewer ACE scores? We don't know that, but it's certainly an intriguing data to look at. I think I've never seen a public health data collection system that I didn't look at the data and ask about 6 more questions. So our data doesn't give us answers, but it gives us more areas to look at. This is breaking it down by income. Not surprising that the people with the higher incomes were fewer that had the 5 or more ACEs. And the highest was less than $1,500 a year income. I was a little bit surprised that there wasn't more of a dose response curve there. So let's talk about opioids. Just to pull opioids and substance use disorder out as to how could that affect these 25 to 34-year-olds that we were looking at. Well, we know that if you have an ACE score of greater than 5, you're more likely to misuse pain medication. You're 5 times more likely to inject drugs. That trauma history makes people more likely to seek treatment for chronic pain, and when they get that opioid, that's when that cascade of events starts. And that in a opioid use disorder clinic, I'll get that out, for young people, greater than 80% of them had at least one trauma in their history, and 2/3 of them had witnessed violence. So you are likely, if you do use opioids and have a high score, you'll have a younger onset of opioid use, you'll have recent IV drug use, previous overdose, and you're at higher risk of relapse. And if it goes back to that basic initial laying down of those neural pathways, if you don't have all those resources, that makes relapse, which a much higher chance of that happening. There was a really nice article that was in the Kentucky School Board journal that they put out, and I just love the picture and the concept as children as the collateral damage for the opioid crisis, and how schools are the support. So if you go back to that life course perspective, and you had the support arrows going up and the risk factors going down, and how schools, and that was the gist of the article. But they noted, and you probably know, that Kentucky is #1 in the country for kinship care. 7% of our children are in kinship care. We are tied for 3rd, unless that's recently changed, and I don't think it has, for the number of grandparents raising children. And you and I both know that the number of grandparents on record raising children is woefully underreported. There are many, many grandparents that are raising children in our Commonwealth today for a variety of reasons. Kentucky is #1 in the country for having a parent or both parents incarcerated. How does a small young brain square in their head that all of a sudden daddy or mama disappear for 5 years of their life or 10 years of their life? How do they handle that, and how do they internalize that and figure out how to cope with that? And we're #6 in the country for childhood poverty. So the children of substance use disorder, the presence of police in their home is not unusual to them. I don't think I was ever closer to a police car than just walking down a sidewalk in my life. They have that fear of parental incarceration. They fear parent overdoses. I won't go into stories about children and what they've tried to do resuscitating their adult parents, or finding them overdosed. And then the inadequate food and housing, clean clothing, looking at all these things. Example of a presence of police in the home. There's a program called Boost that's in Jefferson County, and now they have it in Russell County, Kentucky. This is a program where everyone in the school is trained on trauma-informed care. the bus drivers, cafeteria workers, the teachers' aides, the principals, clerical staff, everybody is trained on trauma-informed care. And they have a code, and I can never remember the name of it. And usually someone texts me that somebody knows that more about this than I do. But they have a system that if anybody in that school, if police go to a child in that school's house the night before, the police department calls the school that morning and says, Connie White, code green. I just made that up. That's not what they call it. The principal then goes to Connie White's homeroom teacher and says, Connie White, code green. That's all they say. But that homeroom teacher knows that Connie White is going to need not equal attention like all the other children in the class. She's going to need a little bit more today because police were at the house. Now, were they there because serving a warrant for someone's arrest, a drug bust? It could have been a break-in. I mean, it may not have been anything nefarious to the family, but that extra trauma alerts the teachers that this child needs a little bit of extra attention. Adequate clothing. One of our groups did a survey in a rural county and asked the kids, what could the school do to really help them out? And it brought me to tears when I saw the survey, and the number one thing they wanted the school to provide was a washer and dryer because they were embarrassed wearing the same dirty clothes to school every day. You know, kids that just want clean clothes because of that self-esteem and how that's going to make them feel about themselves, and how we all feel about ourselves reflects how we interact with others. So we're back to our pyramid, and I think we've gone over that adverse childhood experiences do lead to social, emotional, and cognitive impairment. We adopt risky behaviors, and we also have those inflammatory processes going on at a very young age that continues into adulthood that leads us to disease, disability, social problems, and to an early death. But I'm going to add another twist to this today. This is the revised ACE pyramid. And this is adding a whole new concept of social conditions, local context, generational embodiment, and historic trauma. Well, what in the world does that mean? Those are the adverse community environment. It's another set of ACEs. And we're going to look at how, besides that conception to death that we looked at earlier, how even before that, social conditions, the environment that culture, that group of people have grown up in, will affect what the ACE score is going to be. Not that it's going to be measured in the ACE scores, but it will influence what those ACE scores are going to be. And I absolutely love this chart. And if you don't take anything else home, although I do have a take-home message at the end of the slide, but this is worth pulling up when you get the slides and printing this out and ruminating over this. And I have spent a lot of time looking at it. So you've got your adverse childhood experiences that we talked about up here, and we went through all of these different areas that influence the child and their social emotional development and how they interact with their peers and with their environment and when they become adults. But adverse community environments are a critical piece that we have, I think, conveniently chosen to not address. And I think the events of 2020, with all the things that have happened in 2020, has shown a not just a spotlight, but one of those great big spotlights that you sign up to the sky and you can see it for miles. It has flipped that around and shined a spotlight on adverse community environments. And this is poverty, and that's where we're going to talk about how the tracking network can be helpful there. Years of historic discrimination, community disruption. I live in Frankfurt, and I think we're just now beginning to, 30 years after urban development, an entire community in downtown Frankfurt was completely eliminated because somebody declared it unsavory and they wanted to build a new building. And we are now seeing people coming to the forefront, talking with pride about the sense of community and how hurtful it was when that community was just wiped off the map, just with the snap of the fingers and the signature on a piece of paper, and they disappeared. We know that poor housing and affordability are huge issues for people. Living in a cockroach infested apartment and having a child with asthma, uh, it's unattainable. I attended a meeting, Eleanor Jordan, when she was the director of women in the governor's office. She had every quarter we would go to the Capitol on Saturday morning, and I learned so much because there were people that they would have been the adverse community environments group if we had known that that was the name for it. But they had surveyed a bunch of mothers in the Jefferson County area and asked them, what one thing would you ask of your landlord if you could get your wish to come true? The number one thing was, please put my apartment up to code. They weren't asking for the moon. They just wanted basic, safe, healthy place for them to raise their family. And then violence. We talk about violence up in the ACEs, about violence to mothers and stepmothers, or violence to the person we're interviewing. This is the violence of, yeah, go out and play. I'm not going out to play because I might get shot in a drive-by. Or how many of these children have had a peer in their school suffer from violence. So this is another way to look at it. These first two columns here, the abuse and neglect and household dysfunction, we've covered, I think, rather clearly in ACEs, but this is ACEs plus 5. And you don't have to do a big research project to recognize that experiencing racism, witnessing violence, living in an unsafe neighborhood, living in foster care, and experiencing bullying, even though they're not in our ACE module, will definitely reflect how these children grow up. The other research that's been done by a group in Chicago, which I find absolutely fascinating, is looking at methylation of the DNA. Methylation of your DNA happens when there has been some type of trauma. And they looked at people in the low socioeconomic level, did a bunch of DNA testing on a whole bunch of these folks, and they found that out of 2,500 sites across the DNA on 1,500 genes, they found methylation of DNA. That's about 10% of the whole genome. And we know that when the DNA is methylated, it affects our immune responses to infection, skeletal development, development of nervous system. This is very new research, but it's a way of saying that poverty leaves a mark on the genome. So they're all of these things together in a big pot affect who these children become. So now I'm going to go to the Enviro Health link because I'm going to stop sharing and go to that link. I hope that I do that. And I'm not sure how to get rid of that, but let me. Now, I was able to do this very quickly when we were working. Now, would somebody come on and tell me if they can see that? I don't think I'm on there yet.
Dr. White, we're just seeing your email.
Oh, okay. Well, that's pretty boring. Let's start sharing this. And we'll share this. Okay, there we go. And it said I did something to stop recording, so please say no. All right, now can you see that?
We're still seeing your email. Oh, now we are. Got it.
Okay. All right. So what you're seeing here is on the Enviro Health link. If you go to Data Portal, you will find a link for the Social Vulnerability Index. If you have not gone here, please go. This is a treasure trove of information that you can go in and look at, and I'll start with the vulnerability index. The vulnerability index refers to the resilience of communities, and it looks at external stresses to human health, natural disasters, disease outbreaks. All of these things have been put together into an index for you to look at. So I will pick on Taylor County, since that's where I was born. And if I go to Taylor County, it's going to give me an overall score of 0.6, which is why Taylor County is that color. And then it breaks it down by the 4 ways that this number of 0.6 was determined. So let's look at housing and transportation. You can look over here and it tells you there what the things are looking at for your housing and transportation score. Overcrowding, no vehicle to get anywhere in your community, or the percentage of mobile homes. And I'm not going to go into these in detail. You can look at these later. Your minority status, percent of minority, and percentage of people with limited English. Your household composition, how many are elderly, how many are children, how many are what percent are disabled, and what percent have single family households. And the one that I really wanted to point y'all to today, and I hope I can make that a bit bigger. No, that makes it too big. Sorry. Is letting us look at poverty, percent in poverty, percent unemployment, income per capita, and what percentage of people in that county have no high school diploma. Now, I will say right off, this is older data. This is the most current data that we have. The American Community Survey data will be updated, we hope, soon. But this is the only data that looks at these specific things. So let's just pick a county at random. So right here, I just picked out Union County, and it tells us what percent of the people in Union County live in poverty, what percent unemployed, what the per capita income is for people that live in that county, and what percent have no high school degree. Let's pick a darker colored county, and I know that's Casey County. So 26% of the people in Casey County live in poverty, 9.3 at this time were unemployed. This is the average per capita income, and 26% of the people in that county have no high school diploma. By looking at this in your county or counties that you're working in can sort of give you a concept of how are you going to reach out. How are you going to program things for this particular population? I learned a long time ago from our Office of Health Equity, we don't want to treat people equally. That was what I always thought. We want to treat people equitably. So go back to that life course perspective. We have to treat people where they are. And if they're in a position that they need extra help, that's what we need to do. And the data that you can gain from this social vulnerability index on the Enviro Health Link, I think will be a great starting point for any project that you're doing, whether it has to do with social vulnerability or not. If you're working on diabetes, if you're working on heart disease, if you're working on premature birth, if you're whatever your area of interest, this vulnerability index is critical for you as you start your planning. Now I'm going to go back to the PowerPoint, I hope. Nope. I was so slick with this at our walkthrough. Okay, I'll have to scroll back down to where we were. I apologize. All right, so seeking to cope, these risk factors underlying adult diseases, and they may be coping mechanisms. How often do we get so frustrated with that patient, that client that just doesn't do what we tell them to do? If they just do it, and I'll mention COVID just this one time. If everybody wore their mask and stayed 6 feet apart and used good hand hygiene, think of what a different world we would be in Kentucky right now. And it gets so terribly frustrating sometimes. But we have to step back and remember everybody didn't come from the bubble I grew up in. Everybody doesn't hear that message in the same way. My example that I usually give every time, because it was when I first discovered ACEs and didn't know that that's what it was. I didn't know it was ACEs, but I practiced for 20 years in Frankfurt, OBGYN. I asked questions every day, every visit to the patients in the very same order so that I was sure I didn't forget anything. When you do a lot of obstetrics and you're sleep deprived a lot of the time, you want to make sure you don't forget. And so a question I asked absolutely everybody was, are you a smoker? How much do you smoke? And then I would go through the 31 things that happens to your body when you smoke cigarettes, because I did not want to be that doctor that didn't take the time to carefully explain to people, because I just knew if I explained it to them, they would go, voila, and they would stop smoking. At least that was my misconception at the time. So I had a patient come in, and I knew she was a smoker, and I'd seen her about 5 years. And I said to her, are you still smoking cigarettes? And she said, yes. And for some reason, I got myself off script, fortunately, laid my pen down. That's back when we had pens and papers doing exams. And I said, how old were you when you started smoking? And she said, I was 10. And in Kentucky, a lot of people start that early. My father was smoking before he was, way before he was 10. And I said, well, that's kind of early, but why did you start smoking? And she said, well, I did it because of my father. I said, oh, and I picked my pen back up. Oh, you were trying to defy your father. And she says, not exactly. Um, but he really hated the smell of cigarette smoke. So if he came into my room at night and I smelled like smoke, he would leave me alone. And then her voice quaked and she said, Dr. White, I taught my 8-year-old sister to smoke cigarettes. I was a really bad sister, wasn't I? So, in my effort, in my zeal to be this wonderful doctor that lectured people on what they needed to do to make them healthy, every time I went through those 32 things that she was doing to her body when she smoked, she heard me saying to her, you are causing these 32 things to happen to your sister, and you're a bad person for doing that. And I stopped and looked at her and I said, you are the best sister anybody could ever have. You should be proud of that, and I'm sure your sister is grateful that you saved her from that trauma. So, why don't we talk about why you're smoking now and what kinds of things could I help you with to help you cope in a different way so you don't quit smoking? A completely different way for me to look at that patient. I needed to ask her questions, and then I needed to listen to her answers so that I could give her what she needed, not what was on my checklist that I thought I needed to tell her. So those risk factors, those behaviors that people have are often their way to take a bad experience and make it a better experience for them. And for us to stop that judging, which I was doing, not intentionally. If you'd asked me if I was judging people, I would have said, well, no, I would never do that. But I was, because I wasn't listening to my patients and what they were trying to tell me. I have a friend who works here in Frankfurt at a church program that puts backpacks together for kids and with food in it for the weekend. And there's this one little boy that would bring his backpack in every Monday, and it was filthy. It had mud and grass stains, and it was just a mess. So the ladies would clean it and wash it and dry it and pack it with food, and he would bring it back Monday, and it was filthy. So finally, one of them just got so fed up. She says, we work so hard and we clean this up, and this kid is so disrespectful, and he brings this dirty backpack. I'm just going to ask him what's going on. So she did. She said, Joey, what's up with the backpack? I mean, I work so hard to clean it. Why is it dirty? He says, oh, I figured it out. The first time I took my backpack home, I took it in the house, and all the people, now I don't know who all the people were, but all the people said, oh, food, and they took my backpack and they ate it. So now when I get off the bus, I run around to the back of the house and I throw my backpack under the porch. And then I tell them in the house, They didn't give me any food this weekend. And I can crawl under the porch all weekend long and eat. That's why it's dirty. And this woman just gave him a big hug and she says, "You bring that backpack back every Monday, and I promise you, you will have food every weekend." So, the solution for an 11-year-old to figure that out, he deserves great credit, not us demeaning him for not being clean like we wanted him to be or respectful like we wanted him to be. He was doing exactly what we wanted with that program, and that was to feed himself. These destructive habits, these bad habits, we miss the source if we don't ask some questions. So, resilience is our ability to overcome hardships. The supportive relationships are the basis of that resilience. Um, that's where you get the skill building, the positive reinforcement for self-efficacy, and it requires relationships to have that. So, what do you do if you didn't have that 0 to 2 years old? Those resilience can be built. It's harder. I mean, it's easier if that happens from age 1 of 0 to 2. But that can be built into people if there is that strong adult, caring, nurturing relationship. And it may not be a parent, it may be the wrestling coach, it may be a Sunday school teacher, it may be somebody at the local library, it may be your diabetes educator. All of you out there have been positive factors, up arrows for people your whole life in the work that you do. And you don't know that, but you have been. And it's at making that relationship that gives that person that self-efficacy to say, I am worth being taken care of. I am worth respecting myself, regardless of all the noise that's been going on around me. And you are the ones that make that difference. I think this sums up everything I've said today. Hurt people hurt people. And if we can think about that, I think we can think about ways that we can take those hurt people, that little girl in that picture that I can't look at on the toxic stress slide, and understand that she will think hurting people is normal unless we show her that that's not a normal way to live our lives. So, adverse childhood experiences are not destiny. Early trauma doesn't have to dictate our life story. And it shows us that with a nurturing adult, even if it's an adult we're nurturing, can cushion that impact of adversity in life. So, our take home messages are: exposure to trauma is the single most prevalent risk factor for children today. And I would add to that not only adverse childhood experiences, but adverse community environments. Adversity is the way we learn. If I hadn't had to take tests in medical school, I wouldn't have ever learned things. And it was, I thought, was traumatic at the time, but it's this toxic stress that interrupts learning and our ability to interact with our community. Relationships are necessary for the resilience, and adverse childhood experience are perhaps the major cause of death and disability in adults in our world today. And knowing that we can do better to prevent, mitigate, and treat toxic stress. I want t-shirts that say we can do better. We can do better. And some of you are doing that. Probably all of you are doing that in your own corner of the world. But I think once we understand the background that how adverse childhood experiences affect people, it makes what we do make much more sense. So here are our three babies at the beginning. Remember them, those cute little ones that were patting. Now, this isn't an ad for that commercial, but when I saw that for that bottled water, but when I saw that picture, I thought those are those three babies, and they've grown up into adults. And let's hope that they were given the tools that as adults they can have resilience to deal with others. So every child is one carrying relationship away from a success story, and every adult is one carrying relationship away from a success story if they didn't have that early advantage. So this is a quote from 1832. So ACEs didn't exist back then, but he says, treat people as if they are who they can be, and you will help them become who they're capable of being. I thought that was just brilliant. And that is our charge. Treat them as to who they can be. I took a little poetic license with Frederick Douglass and said that it's easier to build strong children than to repair broken men and women. And then the ultimate philosopher, Oprah, who said when she learned about adverse childhood experiences, it blew my mind and changed my life. And when Oprah gets it, everybody gets it too. So here's my contact information. I'm happy of course, we'll take questions now. I also wanted to share with you the folks at our BRFIS who did all this wonderful data collection and presentation on BRFIS, and they are certainly available for questions if you have specific BRFIS and data questions that are way over my head. So I just wanted to put that out there and thank them for this information. So questions that people have. I see there's a lot in the chat box. I don't know if those are all questions. So Shelly, what do we have?
Okay, a question is, it would seem that the use of community health workers in communities could help meet social needs like clean clothes, rental, up to code, many other things that you mentioned. How can we increase the use of community health workers in Kentucky?
Well, right now there are several things. I'm so proud of the work our department has done on community health workers, and thank you for bringing that up. I very seldom do a presentation that I don't somehow sneak community health workers into the talk. I think they are the backbone of what we're trying to do here. I think they are an extension of our professionals. Have to understand that there are people that can do that. If I'd had a community health worker, I'd probably still be practicing OBGYN because I spent my evenings calling people trying to take care of these kinds of things. And so there was not a lot of time for me. And so I came to public health. Uh, Community health workers, we now have a certification at the state. Our hope is that when we get a certification, this will get us a step closer to getting health insurance to pay for that work so that we can actually bring, instead of having community health workers that work on grants for 3 years or 5 years, if we could actually make this a profession that can be reimbursed, we can really begin to grow the work of community health workers across the state. We do know that we have, the godmother of community health workers down in Kentucky Home Place, in Hazard, and that has grown everywhere across the state. So it is a huge push for the Department for Public Health that we get community health workers not only trained, but continuing education, which we provide. We work with CHIAC, the Association of Community Health Workers, who it's just a community health worker group. So we are all about how important that is for all of these issues. They are on the ground and they understand what people need.
Some people may not know what a community health worker is.
Oh,
Could you
thank
explain?
you. Yes, Shelly. I mean, it's so in my DNA that I don't think of that. Community health worker is someone that looks like you and sounds like you, knows your community. These are people that with a high school degree or an equivalent that go through training and they help people in their home. So you go into somebody's home and you open the refrigerator, and when you see 2 bottles of Mountain Dew, you sit down and say, "So, Julianne, I know you got the sugar, but there's 2 bottles of Mountain Dew in the refrigerator. Let's talk about what you heard him tell you about nutrition. Or let's get those throw rugs up since you just had a stroke and we don't want you to fall and break a hip. Or if you can't get your medicine, let me hook you up with someone who delivers it to your home since you don't have a car." All of those things that if you had a nosy grandmother that lived with you, she would be taking care of all those things, but all of us don't have that luxury. And that's what the community health worker helps you to do, is to connect with the resources in your community to help make you be able to take control of your illness and your life situation, not for it to control you.
We have another question. How preclinical research using animal models could help us in this area? This person says, I have an animal model of early life stress in rodents, and sometimes I am criticized because I am not providing a solution to the ACE problem, just understanding mechanisms linked to cardiovascular disease.
Well, I think we learned so much from animal studies, and I feel for you, because I did at the National Center for Toxicological Research. We were doing teratology, birth defects research, and looking at what happens when mother rats are fed a certain thing, and then what happens to those offspring. And you do get a lot of that. People don't understand that there's such a close connection. So I think any of that kind of work that you're doing, that basic bench science, it's going to help us to direct the work that we do in humans. It is critical. So thank you for doing that, and keep up that good work. That's a tough lift to keep coming in every day and doing that.
Okay, and then I had a question. During your presentation, you said that the Hispanic population had a high ACE score. Why do you think that is? Do you think it's the culture?
I don't have an answer to that. And I
Okay.
don't know the exact number of people that answered that question. That's my first question, although I know that Dr. Kanotra and her group do not report any data unless they have a statistically significant
Okay.
weighted all these. That's why I said, if you have any breakfast questions, ask them, because I don't do the statistics. In my world, my N value is 2, mom and baby, and if you get bigger than 2, I get a little confused. I don't know. I think part of it would have to do with the disadvantage of language barriers, of not knowing where to go for help, of being out of their cultural. The growing up in Kentucky is very different than growing up in a home culture. You don't have that, maybe that multi-generational home that you would have if you were back in your home country. So I think there's a whole host of things that even I don't understand, but it's certainly something that needs to be delved in a greater detail.
Okay. Are there any more questions? Let's see. I don't see any more questions. We do have a brief poll that we would like people to fill out. I think Kara's going to bring that up now.
And Kara and Dr. Lambert have my PowerPoint, so I guess we'll be sharing that with the attendees. Okay, thank you.
So thank you so much, Dr. White. It's Cynthia Lambert again. I've posted a couple times in the chat. There are 2 different surveys. One is for all attendees other than registered health educators. That survey is separate for the CEUs. And then there's the one on SurveyMonkey that everyone, we want everyone to fill that out, not just those of you who need continuing education. And we ask questions about the webinar today, and also what you'd like to see in the future, because this is our last one for 2020. But the committee that planned this is going to be getting back together very early in 2021 and putting together more great programming like this that we were able to bring you this year. And we haven't decided how that's going to happen. In other words, if we're able to get back together face to face, or should we continue to do webinars? And that's another question that we're asking you about, because we've had a really good response from this. So again, thanks, Dr. White. And if you would just click on the links for that survey. And it looks like maybe we have one last question, Dr. White.
Yes, it's what about the impact of fathers? Is that being looked at in more in depth, and specifically fatherhood involvement prenatally and in early years of attachment?
I think that is a critical piece. That comes from someone who had a very involved father in my childhood. But yes, the Department of Behavioral Health is doing some work with fatherhood. I know there was a national push for that, and there's still a national organization looking at that. I think it has to do with how many people are supportive of you. So mother, father, that would be what in our culture would be the ideal, but it may be grandmother. It may be, like I said, the wrestling coach. I love to tell the story about LeBron James, and when he was growing up, and if you don't know who LeBron James is, he's one of the greatest basketball players of all time. And he grew up in Cleveland, and his mother was 16 when he was born. And he told the story about how he loved it because every 3 months they moved and he got to redecorate his bedroom. And he thought that was so cool. And he didn't realize as a child that they were being evicted every 3 months. And so that's why they only lived places for 3 months. And so when he got into his junior high years, that's when his mother, in her great wisdom, went to his basketball coach who had taken a great interest in his life and said, can my son live with you? Because she knew that soon his peers would recognize that he was being evicted every 3 months and he would start getting ridiculed. So she gave her son, gave is a exaggeration, but she turned her son's development over to another family because she knew that would give him stability that he would need and grow into the young man that he, or the man that he is today. So I think the nurturing adult, it's ideal if it is biological, and if that's not possible, then the more support, the better those neural pathways are going to be for future development.
Are there any more questions for Dr. White? You covered things so great, Dr. White, that and we've gotten lots of comments about how great this presentation and your evaluation. We always get wonderful results on evaluation.
It's such a great topic, and it speaks to people so strongly that yes, it's a topic that you want to talk about, because people, once they get hooked, or want to learn more, and it's very exciting. It's very life-changing for me. As me and Oprah, it was life-changing for us. Like this. Thanks, everybody.
Also, I see that there's some people on here that just have first names, or they have maybe their organization or on here. And if you're wanting a certificate of attendance, or you're needing continuing education hours, Cynthia can tell you how to change your name. We really need that information.
Sorry, thanks. I was muted. Yeah, so under the participants, when you pull up the list for yours, you hover on your name, you pull down the thing that says more, and you can rename yourself. I think a lot of them I have figured out today who you are, because I do have your registrations, but sometimes we go back and forth, and I hate people waiting for their CEUs because we have that issue. I see people are changing it. Thank you so much. That makes my job a little bit easier. So thank you. But again, everybody, thanks. It's been great today. So Dr. White, love your passion for this topic. I always enjoy hearing this. So thank you.
Everybody have a great end of the year.
Yeah, thank you.
And as a reminder, this will be available via Train Kentucky. It's our online learning management system. It's free to create an account. It's many of the courses are free, and our entire webinar series will be on Train Kentucky, and we will be offering free continuing education credit hours. So if you know of anybody that's interested in children, interested in environmental health, please share this information with them. And thank you, everyone, for taking part of your day to be with us. We appreciate it. And thank you, Dr. White, for a wonderful presentation. We appreciate you and all the work that you do for public health.
Well, thank you for inviting me and for all these 8 webinars. That's a great work.